challenges that CCGs face. I'm very pleased to have alongside me Robert McGough, who's a partner at DAC Beachcroft, and Robert and colleagues are working with a number of CCGs across the country, I think helping them through some of the legal and governance challenges that they face 10 weeks into their lifeline. So very early days, but I think Robert's going to give us his reflection of some of those challenges and hopefully some tips about how CCGs might tackle them in terms of being safe and able to proceed. So Robert's going to talk for about 20 minutes and then hopefully there'll be a bit of time for some questions, but we absolutely have to finish at 2:30 on the dot, so I'll be a bit mean and chop people off at that point. So over to Robert, thank you.
Thank you very much, Julie. The initial challenge for CCGs was authorisation. Obviously, there's a very complex process around authorisation, which was run through NHS England, or Commissioning Board as it was then. And CCGs, having overcome the obstacles of that process, becoming a new statutory body and engaging their members to create that, that was actually, in effect, only the start of the challenges which CCGs are facing. The NHS has passed on, pinned its hopes on the new commissioning, the new clinical commissioning structures and landscapes. And now they're looking at them to try and transform healthcare. But CCGs, in order to do this, face a series of daunting challenges which are starting to become more and more apparent as we go through this first year. CCGs are already showing that they're going to need to be able to adapt quickly, develop skills and their organisations to meet those challenges. In the current NHS, standing still is no longer an option. My talk today is focused around the legal and governance challenges which CCGs are facing in their first year of operation. Effectively working with a number of CCGs across the country, we're seeing a number of these types of issues occur time and time again. But I'll be the first to admit it's not an exhaustive list, and it doesn't include some of the other key emerging issues which have already been discussed this morning, such as financial allocations to CCGs. But it's important to put all of these issues, I think, together into some form of context. So in terms of scene setting, where are we up to now? All 211 CCGs were authorised for the 1st of April. 105 of them were fully authorised. The majority of the rest, 106, operating under conditions, and there were a small number, 14, that actually received formal directions for their commissioning from NHS England. But that statistic, the reason for saying that is that it shows that even in the authorisation process, there is a clear variance between different CCGs and where they've reached in their development stages so far. It's a mistake to assume that all CCGs are at the same place. They're very separate entities with, from my experience, separate governance systems, separate constitutions, different constitutions. Not everybody followed the model form. And they have very different ways of operating. They're nationally responsible for 65 billion of the 95 billion pound NHS commissioning budget. And some have inherited some massive, deep-rooted historic issues from their PCTs, such as financially unviable NHS providers on their patch. They'll be involved then straight away in future planning. Many CCGs are in discussions already around how they restructure these services that they're starting to commission. And all of this start for CCGs is against the national backdrop of the Nicholson Challenge, 15 to 20 billion pounds worth of savings, the Francis Report with its imperative to improve safety and quality, but also, very importantly, to look at how you manage your provider contracts as well as the movement of a lot of the funding in primary care and specialist services away from what was primary care trusts into NHS England. And CCGs have to tackle all of this themselves in a fledgling commissioning marketplace when the main bodies which are set up there to help and to assist them are actually also new bodies which are also finding their way. So in effect, in setting the scene, I think there's a whole host of serious challenges that CCGs are having to tackle and find their feet with straight away. The 5 key challenges I'm looking at today that I've picked to raise track back to legal and governance issues and points for new CCGs which we're seeing from a legal perspective, from an advisor's perspective, coming up quite a lot. The first one is really understanding the legacy, understanding what you've inherited from the systems following authorisation and following transition across from PCTs and SHAs. The second is how you manage conflicts of interest, where they're inherently likely to occur within an organisation such as a CCG, the crossover in provision and commissioning within that organisation which you represent. Collaboration, better collaboration, more collaboration. There has been a shift towards more local government and social care involvement in the wellbeing debate. Local government is starting to have a more important role as well in CCG decision making. In addition to that, there's a drive backed by a statutory duty on CCGs to actually promote integration across services, which in itself is likely to demand more and more collaborative working from CCGs. Commissioning support services. Some of you may have heard Bob Rickett's presentation yesterday. I think I'm probably speaking at the same time as him today, which doesn't help. But what they're effectively, NHS England are saying, is there are going to be key changes and developments to come for commissioning support units, CSUs, en route to their externalisation. And the CCG's development, as a key customer of those services, is going to play a pivotal role as to how the role of commissioning support relationships is going to work. And the last issue I'll look at will be procurement. Obviously, this is an issue that keeps on coming back and back at time and time again, very much in the public eye with the criticised Section 75 regulations being issued and then reissued, and obviously Monitor has now just issued further guidance as to how you might want to interpret that. It's muddying the waters around the key question of to compete or not to compete. The answer to that question, along with how you choose to compete if you actually decide that that's the right thing to do, is a major challenge for CCGs in being able to deliver their functions appropriately. So the first issue then, understanding the legacy. Obviously on the 1st of April, PCTs and SHAs were dissolved. Their roles and functions were spread across the new commissioning landscape. This was mainly worked out through a transfer scheme. It's a legal document which is a catalogue setting out the claims, liabilities, assets, contracts that were held in these organisations and stating where they were going to go to. A key task for CCGs, and one which we're still seeing is emerging, is a form of due diligence on these contracts, understanding what the contracts, the assets, the liabilities that you think you should be receiving from the PCT or even the SHA, and what you're actually getting under those transfer schemes. In many cases, the information is still actually being finalised within PCT legacy teams, ensuring that the actual final transfer schemes are correct. And obviously, as these documents in effect just transfer over those contracts, the assets, the liabilities, they're actually very important. The destination of the item is going to be important because the obligations will shift with them. And so, for example, a claim and the value and the financial value of that claim could shift across. A contract you may require, a contract you don't want, with a financial obligation attached to it. And then that's why I'm saying reconciling the obligations against finances. A CCG then needs to really understand what it's getting, what the cost is of what it's getting, and whether you've been given the budget to actually pay for all of that. What's the impact going to be on the operation of your CCG from what you're actually getting? And once you've done that, when you've got to that stage, it's effectively then looking how you take that forward. Before you can move forward and understand and set a clear contracting and commissioning strategy, you need to understand the contracts and commissioning activity that you've actually got from the past. So CCGs, for example, may want to look through their contracts, carry out due diligence on what they've got and the terms they've got, and then look to terminate or vary certain contracts, depending upon the terms of them. Also, they could start to consider how these contracts can be managed going forward in terms of commissioning support services, how that ties in with the commissioning strategy. And also, a further caveat to that is integration. If you don't understand all of the contracts you've got, how can you then start to look at how that works across a number of different services, a number of different pathways? How can you have integration if you don't really know what you've got there in the first place? You could go out and commission a service and then realise actually you've done it and the entire rest of your area have gone out and commissioned a different service themselves because you didn't realise that you actually had that service there. So it's important for CCGs in the first instance to be very clear and understand what their legacy is. Managing conflicts of interest is a key recurring topic for CCGs. All CCGs, obviously legally, as a lawyer I will tell you, have to have a constitution which will set out how you're going to manage and deal with conflicts of interest, how you're going to have a register of conflicts of interest, how that's going to be maintained and obviously managed. And this needs to be implemented in practice. It's all very well having something within a constitution, but if you don't implement and run with that in practice, then effectively it's not going to work. Robust conflict of interest policies and procedures will help you to embed that into more of a culture of transparency, which is part of the way really which CCGs were actually designed to be set up. Policies, though, are not enough on their own. I've seen a number of examples where CCGs have sent out declarations of interest to GP members. They've come back not being correctly completed or incorrect items put in or items which aren't conflicts of interest recorded. It's tricky, it's difficult. Members need education and they need to effectively understand what should be or should not be a conflict. It doesn't help the legislation, doesn't really clearly set out what a conflict of interest should be. There's lots of reams of guidance that are coming out from a number of different bodies. It's quite tricky then for CCGs to be quite definitive on that point. But I'd also want to really emphasise that the existence of a conflict of interest does not mean that a member has acted inappropriately, unprofessionally, or done anything wrong. In some areas for CCGs, the GPs may have a natural conflict of interest just because of what the way they've set up. It may be completely unavoidable because of the way they actually provide some additional services on top of their GP practice. However, what the CCGs do need to do is ensure that the conflicts are identified, recorded, and then managed appropriately and transparently. And it remains the CCG's responsibility ultimately to be fully responsible and ensure that the potential conflict of interest is recorded, even if you've actually delegating something off to a commissioning support provider. The CCG still retains ultimate accountability for all of those things. CCGs, in terms of how they actually then manage any conflicts of interest that come up, some CCGs that we've been working with have actually set up independent review panels within the CCG for conflicts of interest, and especially when they're looking at bids, commissioning and procurement, where a number of very complex conflicts could actually arise. And it's also particularly complex where governing body members of the CCG get involved in these conflicts. But I would remind you that CCGs actually do have the advantage. They have 2 lay members, you have a registered nurse, and you have a secondary care doctor on your governing body. A number of CCGs we've worked with have used that grouping, the independent people, to act almost as a separate panel which can help you to review conflicts of interest and ensure that that's managed in a transparent way independently from potentially body members who actually do have a conflict. It's important to remember that conflicts are not a one-off check. They can emerge at any point. For example, a GP who sets up a specification for a new community service and then his company later on decides that it would like to bid for that service. There's a potential for a conflict of interest to arrive there. It should be subject to a process of ongoing identification and monitoring. What we'd recommend is that CCGs should really look to have standing items on meeting agendas and declarations around conflicts of interest. Also include it within the commissioning documentation as well, to make sure that's absolutely clear throughout the organisation there's a culture of disclosure of all the conflicts. It's especially important at the moment because CCGs are very, very high profile. If a CCG takes a view on a conflict and decides it's not that important, or it ignores a conflict, or it fails to follow a proper process to manage that conflict, it's likely to be newsworthy in the current climate. Given the inherent conflict for CCGs as having providers and commissioners within the organisation, the public and other providers will need to be given reassurance that the CCG is effectively making unbiased and fair decisions. And to manage the risk of perception that they're not, CCGs need to make sure that they record and evidence the steps that they're taking to ensure that they're doing this fairly. And I mean, when you see these things going wrong, you only need to look at the major national press and you see headlines such as GP links to private healthcare firms spark fear of conflicts of interest, which was The Guardian, very nice and standard, to the slightly more sensational GP private firms grab NHS cash, which bizarrely enough was the Sunday Times, or doctors hurry to join NHS Gold Rush, another Sunday Times one. You can see the perceptions that can be created outside of CCGs if these items are not managed correctly. Collaboration. Collaborative working is becoming increasingly important for CCGs, starting from working together to achieve economies of scale, looking at some of your back office functions. Moving on to where you have large providers on your patch, which could have 3 or 4 commissioning CCGs working with them, collaborating together to manage those contracts more effectively makes sense. And the Health and Social Care Act has provided you with the power. It enables CCGs to establish appropriate collaborative arrangements with other CCGs. Each CCG, though, again, will still need to retain its own accountability for the commissioning of services for its own population. An example that I've seen where this has not worked quite so well was a CCG who decided within the first couple of weeks after being authorised that what it wanted to do was terminate a large mental health provider because it didn't think it was doing a good enough job, within a couple of weeks of obviously coming in after authorisation. They tried to give notice under that contract, but what they hadn't actually appreciated was that that contract was actually shared across 8 CCGs across a whole region, and they hadn't spoken to any of those other CCGs, and they hadn't actually discussed whether that was the method that they should try and do. Now that's obviously an example of not a very joined up collaborative way of working, but we're also working with other CCGs, such as a group in Leicester, where 3 CCGs have worked together pre-authorisation to manage all of their contracts. They've set up various bodies where they debate all the issues that arise on the provider contracts and work together very effectively and making efficiencies together by working all together in a joined up collaborative fashion. So It is possible, but there needs to be the communication between the CCGs for that to happen. It's also important for CCGs to look at how they're going to commission services together from a perspective of allowing integrated pathways of care, from allowing integrated provision across a whole region. For example, I've seen a recent instance of a patient transport service which there was an intention to do a region-wide patient transport service procurement, but one CCG hadn't been attending the meetings and had decided to actually issue a notice and go out on its own to procure that service on a small level just for itself. There needs to be communication. CCGs need to work together. You have a statutory duty to promote integration. Working with social care and health and wellbeing boards is also an important new area of collaborative working for CCGs. Local authorities can be a very complicated body to work with, not least because when you look at how they work geographically, they're working geographically, you're working on a list-based population. So collaborative arrangements could have several local authorities or several CCGs involved within them. Beyond health and wellbeing boards, there's nothing really new in the Health and Social Care Act to give you a new tool as to how you can collaborate better with local authorities. Section 75 arrangements allow you to collaborate with a local authority as a CCG, but beyond that you need to be careful from a CCG perspective as to how you actually do collaborate. Working on joint committees is tricky under the terms of the legislation. You need to ensure that your governance structures properly allow it and that your scheme of delegation actually also functions to allow that to work properly and that you're not taking decisions outside of your control. Health and wellbeing boards have been formed by local authorities. They have a duty to promote integration across health and social care. When they initially came out, there was a lot of debate about whether they were any good. They appeared to be fairly toothless, but a lot of people are changing their views around health and wellbeing boards as we're seeing them start to come into practice. CCGs, for example, have a duty to consult with the Health and Wellbeing Board on your commissioning plans. So despite an initial impression, it appears they could offer a very useful conduit for health and social care and local authorities and CCGs to actually come together and develop a much more collaborative approach for health and social care. And obviously that's going to take time, but there's clear potential that closer working with health and wellbeing boards could bring in a more collaborative way of working. Commissioning support relationships are also something which is in a bit of an evolutionary state for the first year of CCGs. CCGs are still effectively very new organisations, developing relationships with your providers of commissioning support, but you're now becoming around 10 weeks post-authorisation in a better position to begin to understand exactly what the shape and nature of commissioning support you're likely to need. And actually, that may well not be what previously the PCT was provided with. But from a CCG perspective, you also need to be aware of the fact that in a lot of cases, your main provider, the commissioning support unit, is also developing and changing themselves. There's national issues that are arising within that. CSUs are finding their feet in a new environment, and they're looking to develop their own commercial models for future service delivery to CCGs. But the key point here is that CCGs must maintain the capability not only to judge the quality of the services which are provided to you by a commissioning support provider, but also to give the CSUs clear, unambiguous direction about what your requirements actually are, what you need them to provide, and any future services that you feel also they should be looking to provide to you. Contractually, from a legal point of view, when you first entered into the arrangements, it was a service level agreement, an SLA with the CSU, which is at a high level. It needed to be because people weren't really very clear, the organisations weren't fully formed, so they were at a high level, not particularly very enforceable and not very workable in a lot of instances. However, this now needs to evolve onto a much more contractual footing as we look forward. There needs to be more obligations between the two parties. As a CCG, you need to start looking at what is it that you want to measure, what services you actually want to receive from the CSU or commissioning service provider, how you're going to measure it, how you're also going to reward them for it as well. So effectively it's moving from the initial very high level procedure into something which is now going to be much more of a contractual and commercial relationship between you and your commissioning support provider. CSUs, as I said, are looking to externalise and get a degree of autonomy. There's likely to be competition, as Bob Ricketts will be saying in his presentation today, between CSUs and with some private sector providers for commissioning support services as we move forward. So it's important for the CCGs to be an intelligent customer of your commissioning support services and to understand what it is you need and to know when you're getting the right support at the right level to meet your requirements. And it remains very important. If I give you an example, for some commissioning support relations providers will provide contract management services, and they'll in effect that may fit in with some of the Francis report recommendations that you need to have effective management of your provider contracts. But if your support provider fails, then in effect it's the CCG which is responsible. NHS England will be looking to you because it was your function, your responsibility which was failed. So the onus is very much on the CCG to ensure that it gets the right form of commissioning support. Procurement. Procurement is a topic which we could talk about for days and days without getting to the bottom, or in some areas getting very clear about what really should be done with it. But you'll be very glad to hear that that's not what we're going to do today. CCGs are beginning to start looking forward. You're beginning to plan commissioning strategies, planning for the procurement of contracts from April next year beyond. Large procurements are starting to come through from CCGs. Services such as local enhanced services, looking at some of the transforming community services which are coming up for re-procurement in the next year or so. These are all large procurement exercises which are coming up for CCGs. Key to their plans and the commissioning strategy for this and the delivery will be how you understand the procurement regulations. And both the CCG and its commissioning support providers need to understand this. How you comply with the regulations and also how you demonstrate that you're complying with it is important and key to mitigating the risk of being challenged by providers. It's no exaggeration to say it's become, from a legal perspective, it's become a major stream of work for lawyers, the sheer number of procurement challenges which are now coming through. From a trickle a few years ago, they're now very regular. Providers will rattle the sabre even if they don't feel they particularly have a very strong case in many instances. And so, as I said at the outset, when and how you compete services is going to be an absolutely key question. This remains the case following the Section 75 regulations, which didn't really clarify exactly what the position would be there, and also the monitor guidance and consultation, which still leaves a degree of doubt. So from a CCG's perspective, you need to be considering very carefully, is there a market for these services? Are there other providers for these services? Is this a service which then we're likely to be very challenged if we just try and go out and award a contract? Can we justify a decision not to compete the contract? And also, very importantly, from your provider's perspective, can we justify a decision to take that service out to competition? And how are we going to actually show that we've taken that decision? Where is our audit trail? And I think some of the furore around the regulations, actually, there's a lot of good practice within there that you need to record, you need to audit the decisions that you're taking when you're looking at any procurement decision of that type. Also, you need to be looking that your conflict of interest policies and procedures are very tight and operate effectively to demonstrate that there's transparency and fair procurement practice, particularly in light of the procurement regulations, and that you're not showing any unfair treatment or benefit potentially for members of the CCG. It's key, as I say, when you're planning procurements which are going to involve CCG members, that you have that clear, transparent process and you show that from the start. And it's also very much key to ensure that your commissioning support provider also understands the regulations. Now, one thing I would say is obviously for procurement you should take appropriate advice. I would say that as a lawyer, so I probably need to declare a conflict of interest at that point for myself. And it's better to do this prior to taking the decision rather than after it. I had a group of GPs who were in a CCG who came to me a couple of weeks ago and asked about a particular arrangement. They were looking to set up a company and then award a contract to that company through the CCG without competition. And actually, by coming and getting the right advice at the start, they're able to go back and try and work things through and do it in an appropriate and a defensible way and in a way that can be recorded by the organisation. But we've seen plenty of examples where organisations have gone off and just awarded contracts and then they come to you when you're being challenged. It's far better to go up front and then you actually get the protection of having an audit trail of having done that as well. So, in conclusion and summary, there are clear major challenges for CCGs and the health sector generally which are facing you, both in the legal and general context. Implementation of the Francis report recommendations, dealing with sustainability of your providers, dealing with the procurement and the confusion around the procurement regulations, developing integration, managing the relationship between integration and competition, to name but a few. CCGs need to be ready to adapt in order to achieve the best services for their population. What's worked for PCTs in the past may not work for CCGs. So you'll need to look forward, look at your governance arrangements, look at your policies, look at your legal procedures. Are these working in practice? Do they need to be developed? Do they need to be changed? CCGs are new member organisations. They're different. They're a different type of NHS body. So they need to adapt and act in order to meet the challenges, all of these challenges, and be able to survive in this environment. Thank you.
Thank you, Robert.